My Asperger Wikipedia video continued. Diagnosis is most commonly made between the ages of 4 and 11. A comprehensive assessment involves a multidisciplinary team that observes multiple a comprehensive diagnosis is most commonly made between the ages of 4 and 11. A comprehensive assessment involves a multidisciplinary team that observes across multiple settings and includes neurological and genetic assessment, as well as tests for cognition, psychomotor function, verbal and nonverbal strengths and weaknesses, style, learning, and skills for independent living. The gold standard in diagnosing ASDs combines critical judgment with autism diagnostic interview, revised ADIR, a semi-structured parent interview, and the Autism Diagnostic Observation Schedule, ADOS, a conversation and play-based interview with the child. The later mistaken diagnosis can be traumatic for individuals and families. For example, misdiagnosis can lead to medications that worsen behavior. Underdiagnosis and overdiagnosis may be problems. The cost and difficulty of screening and assessment can delay diagnosis. Conversely, the increasing popularity of drug treatment options and the expansion of benefits has motivated providers to overdiagnose ASD. There are indications, as has been diagnosed more frequently in recent years, partly as residual diagnosis for children of normal intelligence who are not autistic but have social difficulties. There are questions about the external validity of the AS diagnosis. That is, it is unclear whether there is a practical benefit in distinguishing AS from high functioning autism and from PDD-NOS. The same child can receive different diagnoses depending on the screening tool. The debate about distinguishing AS from high-functioning autism is partly due to a tautological dilemma where disorders are defined based on severity of impairment, so that studies that appear to confirm differences based on severity are to be expected. Differential diagnosis. Many children with AS are initially misdiagnosed with attention deficit hyperactivity disorder, ADHD. Diagnosing adults is more challenging as standard diagnostic criteria are designed for children and the expression of AS changes with age. Adult diagnosis requires painstaking clinical examination and thorough medical history gained from both the individual and other people who know the person, focusing on childhood behavior. Conditions that must be considered in a differential diagnosis along with ADHD include other ASDs, the schizophrenia spectrum personality disorders, obsessive compulsive disorder, major depressive disorder, somatic pragmatic disorder, nonverbal learning disorder, social anxiety disorder, Tourette syndrome, stereotypic movement disorder, bipolar disorder, social cognitive deficits due to brain damage from alcohol abuse, and obsessive compulsive personality disorder. Parents of children with Asperger's syndrome can typically trace differences in their child development to as early as 30 months of age. Developmental screening during a routine checkup by a general practitioner or pediatrician may identify signs that warrant further investigation. The United States Preventive Services Task Force in 2016 found it was unclear if screening was beneficial or harmful among children in whom there are no concerns. The diagnosis of AS is complicated by the use of several different screening instruments, including the Asperger Syndrome Diagnostic Scale, ASDS, Autism Spectrum Screening Questionnaire, Childhood Autism Spectrum Test, CAST, previously called the Childhood Asperger Syndrome Test, Gilliam-Asperger's Disorder Scale, Krug-Asperger Disorder Index, and the Autism Spectrum Quotient, with versions for children, adolescents, and adults. None have been shown to reliably differentiate between AS and other ASDs. Management. Asperger's syndrome treatment attempts to manage distressing symptoms and to teach age-appropriate social communication and vocational skills that are not naturally acquired during development, with intervention tailored to the needs of the individual based on multidisciplinary assessment. Although progress has been made, data supporting the efficiency of particular interventions are limited. Therapies. The ideal treatment for AS coordinates therapies that address core symptoms of the disorder, including poor communication skills and obsessive or repetitive routines. While most professionals agree that the earlier the intervention, the better, there is no single best treatment package. AS treatment resembles that of other high-functioning ASDs, except that it takes into account the linguistic capabilities, verbal strengths, and nonverbal vulnerabilities of individuals with AS. A typical program generally includes a positive behavior support procedure, includes training and support of patients and school faculty in behavior management strategies to use in home and school, and applied behavior analysis, ABA technique called social skills training for more effective interpersonal interactions. Cognitive behavioral therapy to improve stress management relating to anxiety or explosive emotions and to cut back on obsessive interests and repetitive routines. Medication for coexisting conditions such as major depressive disorder and anxiety disorders, occupational or physical therapy to assist with poor sensory processing and motor coordination, and social communication intervention, which is specialized speech therapy to help with the pragmatics and give and take of normal conversations. Of the many studies on behavior-based early intervention programs, most are case reports of up to 5 participants and typically examine a few problem behaviors such as self-injury, aggression, non-compliance, stereotypes, or spontaneous language. Unintended side effects are largely ignored. Despite the popularity of social skills training, its effectiveness is not firmly established. A randomized controlled study of a model for training patients in problem behaviors in their children with AS showed that parents attending a one-day workshop of 6 individual lessons reported fewer behavioral problems, while parents receiving the individual lessons reported less intense behavioral problems in their AS children. Vocational training is important to teach job interview etiquette and workplace behavior to older children and adults with AS, and organization software and personal data assistance can improve the work and life management of people with AS. Medications. No medications directly treat the core symptoms of AS, although research into the efficacy of pharmaceutical intervention for AS is limited. It is essential to diagnose and treat comorbid conditions, deficits in self-identifying emotions, or observing effects of one behavior on others can make it difficult for individuals with AS to see why medication may be appropriate. Medication can be effective in combination with behavioral interventions and environmental accommodations in treating comorbid symptoms such as anxiety disorders, major depressive disorder, inattention, and aggression. Okay, I'm gonna stop the video, and because I have prognosis to do and epidemiology, and then I have history and society and culture. So there is going to be another section, another video. Peace out, YouTube.